Okay, hello again, everyone. Good morning, good afternoon, or good evening, depending on where you are in the world. We really appreciate you being here with us today, and welcome to the next in Bruin Biometrics Getting to Zero webinar series. Today, we'll discuss how better prevention starts with biology and why pressure injuries persist despite endless prevention options. This session isn't just about another product. It's about why the current standard of care is inadequate and how using biology can fill gaps left by risk assessment, visual skin assessment, and endless interventions to make prevention reliable and effective. We are very pleased to have with us here Dr. Rhonda Sullivan. Dr. Sullivan is the Vice President of Implementation and Clinical Outcomes at Bruin Biometrics. In addition to being a double doctorate prepared nurse, Dr. Sullivan has worked as a certified woundostomy nurse for 26 years and has been certified as a legal nurse consultant for over 20 years. She's also certified as a nurse executive, safe patient handling associate, and a Lean Six Sigma black belt. Dr. Sullivan is a published author, award-winning researcher, medical legal expert, and approved CE provider for 17 boards of nursing. So needless to say, we are very pleased to have Dr. Sullivan on our team and here with us today, taking time out of her very busy schedule. So thank you, Rhonda, and over to you.
Thank you, Ryan. So by the end of today's session, you'll understand how pressure injuries progress, why sub-epidermal moisture occurs, and why SIM compensates for limitations in the current standard of care. We will also explain how biology-driven assessment can improve care, documentation, and outcomes. Over time, pressure injury prevention has evolved. We've added layer after layer, from clinical judgment and structured risk scores to visual and seemingly comprehensive skin assessments. The problem is that all of these processes are subjective and rely on signs and symptoms to diagnose injury. Additionally, none of them allow the clinician to see what is happening beneath the skin, where pressure injuries start. So despite the complexity of our current pressure injury prevention approach, outcomes are moving in the wrong direction. 2.5 million patients are harmed by pressure injuries annually in the US. Severe pressure injuries rose 49% from 2019 to 2025, and 60,000 patients die each year because of pressure injuries. In healthcare, we don't use signs and symptoms alone. We use objective signals to act early and improve outcomes. With sepsis, look sick isn't the threshold. Symptoms can be vague and subjective. We confirm risk with biology, such as vitals and labs like lactate. Then we act early to prevent shock and organ failure. Pressure injury prevention needs the same approach. With stroke, symptoms can be subtle. Confusion does not confirm a brain injury. That's why we don't rely on our senses. We confirm with rapid urgent imaging, then activate time-critical pathways. Pressure injury prevention needs the same standard. Still not convinced that biology is the way to outcomes? Troponin confirms myocardial injury. Continuous glucose monitoring diagnoses hyper or hypoglycemia. ABGs reveal respiratory failure, and D-dimers plus imaging clarifies pulmonary embolism. Most clinical conditions are diagnosed or confirmed using objective measures of patient-specific biological markers and physiologic parameters rather than relying solely on subjective assessment. But that's not the case today with pressure injuries. Preventable pressure injuries persist because we still rely on subjective risk scoring and visual skin assessment. These are tools with known limitations that miss early tissue damage, and they drive inconsistent variable interventions. In most of healthcare, we don't accept known gaps in measurement to guide care. So why is pressure injury prevention different? Take risk assessment, for instance. A 2025 umbrella review spanning 19 systematic reviews and 70 tools, including machine learning models, highlights the risk of relying on risk scores to guide care. Yes, the output looks quantitative, but the inputs are often subjective, error-prone, and incomplete, and missing key risks like oxygenation, perfusion, and medical devices. And no risk assessment tool accounts for skin tone, despite evidence that people with darker skin tones face higher risk, more severe injury, and worse outcomes. Most importantly, large-scale studies consistently show that risk assessment has little to no impact on pressure injury incidents. So why do we still lean on it so heavily? Just because it's how we've always done it doesn't mean it's how it should be done. Maybe it's time to rethink risk assessment, and I know that many clinicians across the country are already doing so. Let's look at comprehensive skin assessment, which sounds reassuring, but without biology, comprehensiveness is just an illusion. Today's standard is still visual plus tactile assessment, making skin assessment inherently subjective, variable, and dependent on experience and context. Early damage often develops below the surface, so skin can look normal when a deep tissue injury is evolving, especially when visual cues are different or obscured in darker skin tones. In fact, visual skin assessment accuracy can range from 16.6% to 71.63%, meaning it can be catastrophically wrong more than it's right. That's why we need objective physiologic signs to detect tissue stress earlier than we can see it or feel it. If you would like to learn more, we have webinars on both risk assessment and skin assessment on our website. Before we even talk about the challenges of access to an endless list of interventions, we must name the root cause of the problem. We're choosing, bundling, and even implementing an abundance of prevention strategies based on flawed risk scores and incomplete skin assessments. Doing so fragments time and attention, increases gaps and omissions, adds documentation without adding value, and can actually deprioritize prevention at the bedside. So even when we do more, delivery becomes inconsistent, and that inconsistency leaves patients, nurses, and organizations vulnerable. I know that clinicians are doing the best that they can with the tools and time available. But as evidence evolves, we have an opportunity to strengthen prevention, because when we know more, we can do better for patients. First, let's dive into the biology of pressure injuries. All pressure injuries start with a triggering event, whereby pressure and shear disrupt blood flow, deform tissue, and damage cells. The body responds with inflammation, and the cells become stressed and begin to die. Fluid leaks into the dermis and subdermis. That fluid is sub-epidermal moisture, or SEM, also known as persistent focal edema. SEM is the earliest biologic sign of tissue stress and evolving deep tissue injury, and it develops 3 to 10 days before visual skin damage occurs. SEM assessment allows clinicians to detect what the eye cannot see, intervene sooner, and stop the cascade before a visible pressure injury occurs. Like everything else in healthcare, pressure injury prevention needs a biological marker, because risk assessments tell us who's vulnerable, but not where injury is developing. And visual skin assessment only shows what's already visible, but negates the fact that damage starts below the skin surface. These assessment gaps drive wasted effort, variation, and preventable harm. Sub-epidermal moisture is the biological marker that helps close these known pressure injury detection gaps. Now let's use the evidence to understand the value of SEM assessment as a pressure injury prevention strategy. SEM-guided pressure injury prevention is evidence-based and consistently outperforms subjective approaches. Across published studies, SEM is statistically superior to usual care, structured risk assessment, visual skin assessment, and clinical judgment, supporting SEM as a best practice for earlier identification of tissue compromise and a more targeted preventive intervention. SEM assessment is backed by more than 200 pieces of evidence and 90+ peer-reviewed publications, including systematic reviews, consensus guidelines, and health economic studies. Biology should be the foundation of pressure injury prevention. Like blood pressure or an EKG, SIM is an objective signal that can trigger earlier, evidence-based intervention. SIM makes skin and tissue assessment valid and reliable, with sensitivity up to 100%, specificity around 83%, strong inter-rater reliability among trained users, and an area under the curve of up to 90 or 0.91, representing excellent discrimination and a true positive rate 91% of the time. SIM enhances standard skin and tissue assessment by objectively detecting early pressure and shear-related tissue compromise, including stage 1 and deep tissue pressure injury before changes are visible. Because early injury is cellular and often subclinical, visual assessments can be time-consuming and have limited diagnostic accuracy. SIM addresses these limitations by measuring the biologic response to pressure and shear. As damage develops, biocapacitance increases. SIM assessment samples multiple sites across the sacrum and heels, then calculates a SIM delta, the max-min difference across the site. The delta cut score of 0.6 is not only clear and easy to interpret, but also statistically derived. Pressure injury prevention should be guided by objective tissue physiology, not subjective assessment alone. SIM provides a rapid, evidence-based measurement with a statistically validated cut score to support early clinical decision-making. A SIM delta less than or equal to 0.5 rules out pressure injuries, while a SIM delta greater than or equal to 0.6 indicates an early, often non-visible pressure injury, and should prompt targeted preventive escalation before damage becomes apparent. SIM provides clinicians an objective, earlier signal of pressure-related tissue compromise, often 3 to 10 days before visual skin changes occur. That window enables timely escalation of targeted prevention while damage is still microscopic and potentially reversible. By acting earlier, teams can preserve skin integrity, reduce progression to visible injury, and prevent pressure injuries from developing. SIM makes comprehensive skin assessment truly comprehensive by providing an objective SIM delta at each anatomical site. SIM tells you who has a non-visible pressure injury, when the pressure injury is developing, and where the pressure injury is developing. Rather than applying a single global risk score, clinicians can interpret each site independently and tailor prevention to where tissue is demonstrating stress. When a delta is low, current prevention strategies can be continued. When a delta is elevated, care should be reassessed and escalated in a targeted way. For each elevated delta, clinicians can systematically confirm, are the interventions in place? Are they being executed correctly? And are they working? If the interventions are working, the SIM delta will trend down toward normal. Skin tone diversity can increase pressure injury risk because the visual cues clinicians are trained to identify, particularly early erythema or purple discoloration, may present differently or be under-recognized in patients with darker skin tones, leading to delayed detection and delayed intervention. The evidence shows that these patients have a 60% greater risk of pressure injuries, are more likely to develop multiple or higher stage injuries, and are 4 times more likely to die from pressure injury related causes. A key driver is under-detection in the earliest stages, when skin changes may not appear in the classic way. SIM assessment addresses this equity gap by providing an objective physiologic measure that is independent of skin tone, enabling early identification of tissue compromise across all populations. In practice, integrating SIM into prevention workflows supports more consistent, equitable risk stratification, and targeted escalation, helping ensure the same standard of early detection and prevention for every patient. Now that we've reviewed the biology of subepidermal moisture and early tissue injury, here's the practical, clinical, and financial impact. First, SIM assessment enables objective pressure injury detection at the point of admission, including identification and documentation of stage 1 and deep tissue pressure injury before changes are visible on the skin surface. A SIM delta greater than or equal to 0.6 is consistent with at least a stage 1, while 3 escalating deltas indicate an acceleration pattern consistent with the developing deep tissue pressure injury. Using SIM assessment to augment admission assessment strengthens present on admission documentation and establishes a more accurate baseline for ongoing assessment. Importantly, injuries determined to be present on admission are by definition not hospital acquired, supporting more accurate reporting and appropriate attribution. SIM assessment provides an objective biomarker of pressure and shear-induced tissue injury, enabling clinicians to distinguish pressure injury from non-pressure-related skin findings. An elevated delta indicates the presence of a pressure injury, and a normal delta represents a non-pressure-related etiology, such as hyperpigmentation. This clear differentiation reduces misclassification, prevents non-pressure-related conditions from being reported as HAPIs, and improves the accuracy and consistency of HAPI reporting. SIM-guided pressure injury prevention makes skin and tissue assessment clinically effective by translating early physiologic changes into timely targeted interventions. Across 34 care facilities, SIM implementation has been associated with a 90.5% reduction in pressure injuries across acute and post-acute settings. In acute care alone, 74% of the facilities reported 0 acquired pressure injuries, and 87% achieved reductions greater than 80%, demonstrating a consistent real-world impact. Importantly, 100% HAPI reduction has been achieved in multiple implementations across the care continuum, and SIM has shown benefit regardless of the baseline robustness of an organization's prevention program. The rationale is that SIM adds an objective, actionable measure that standardizes detection and escalation. SIM-guided pressure injury prevention reduces waste by focusing intensive prevention on the patients and anatomical sites where it offers the greatest benefit, rather than unnecessarily applying the same interventions universally. In a quality improvement project on a 20-bed older adult unit, SIM-guided prevention reduced unnecessary workload while improving outcomes. Unnecessary patient repositioning fell 55%, saving 7.15 nursing hours per day, and pressure injury rates dropped from 5.77 to 0 per 1,000 occupied bed days. Staff also reported meaningful practice improvements, with 100% noticing increased pressure injury prevention knowledge and 49% changing to person-centered care based on SIM results. Downstream, organizations have reported substantial resource gains, including 1,420 hours of nursing time saved and 5,637 bed days avoided, and reduced use of dressing, support surfaces, and treatment complications such as infection. SIM-guided prevention has demonstrated measurable economic and clinical value across multiple health systems worldwide. In U.S. cost-effective modeling, based on clinical trial data, adding SIM to existing prevention protocols was a dominant strategy, lowering cost while improving outcomes and delivering approximately $4,054 in savings per acute care admission. And for every 1,000 high-risk admissions, 7 deaths were averted and rehospitalization was reduced by 206 bed days, while delivering a rapid ROI in 1 week of use. In Canada, a real-world acute care pilot achieved a 100% reduction in facility-acquired pressure injuries with over $400,000 in annualized unit savings while materially changing clinical decision-making. Based on work done by Geffen et al. For an average UK trust with approximately 40,000 admissions per year, the estimated total financial savings from implementing the SIM scanner would range between 600,000 and 3.3 million pounds each year. Globally, these results show that objective SIM-guided care improves prevention precision, reduces avoidable harm, and delivers rapid material ROI. Pressure injuries aren't just a clinical harm. They create regulatory exposure, reimbursement risk, and legal liability. Severe HAPIs can lead to litigation, direct financial penalties, and increased scrutiny through Joint Commission ORICs, state adverse event reporting, and multiple CMS programs, including MDS reporting, HAC reporting, and the Hospital Inpatient Quality Reporting Program, or IQR. Under IQR, electronic clinical quality measures will require mandatory reporting of stage 2 or greater HAPIs in calendar year 2028, which is October 1st, 2027. Pressure injuries also drive indirect financial impact. Greater HAPI severity is linked to higher risk of other hospital-acquired conditions such as pneumonia, UTIs, and sepsis, as well as higher readmissions, longer length of stay, higher costs, complications of care, and increased mortality. All of these can worsen performance under programs such as value-based purchasing and readmission reduction programs. While pressure injuries aren't directly included in the CMS Transforming Episode Accountability Model, or TEAMS, 5 surgical procedures with high rates of intraoperative and postoperative pressure injuries are included. TEAMS is a reconciliation payment repayment model, whereby strong performance, meaning those with a lower cost of care, earn additional money, and poor performers, or those with a higher cost of care, pay money. And remember, HAPIs increase cost of care and triple readmission risk. It is important to note that many of these programs penalize the same poor outcomes multiple times. For example, suboptimal pressure injury prevention performance can be penalized repeatedly under different reimbursement programs. By enabling early objective detection and more accurate differentiation and documentation, SIM assessment supports stronger prevention and more consistent reporting, reducing HAPI incidents and the downstream regulatory and legal consequences. As we close, it's worth stepping back to a single practical truth. There is only one technology that enables clinicians to use biology to identify, treat, and prevent pressure injuries, the Provisio SIM scanner. Pressure injury development is a biologic process that begins below the skin surface, 3 to 10 days before visual changes. If we want earlier detection and more precise prevention, we need tools that measure that underlying physiology, not tools that infer risk or rely on appearance. While other devices may claim to detect pressure injuries, even deep tissue pressure injuries, they are not authorized or indicated for pressure injury identification, and using any device beyond its cleared intended use exposes patients, clinicians, and organizations to unnecessary risk. The Provisio SIM scanner is the only FDA-cleared, non-invasive skin and tissue assessment technology for pressure injury management, and the only SIM assessment technology cleared for this purpose. It provides an objective assessment of sub-epidermal moisture, delivers a validated and easy-to-interpret cut score to guide intervention, and supports consistent anatomy-specific decisions so clinicians can intervene earlier, document more accurately, and prevent harm. The Provisio SIM scanner is also the only skin and tissue assessment technology with an ICD-10 PCS code and a direct coding pathway for present on admission through the ICD-10 diagnosis code for stage 1, because subepidermal moisture and persistent focal edema are synonymous. If pressure injuries are biologic, then prevention should be biologic. And today, there is only one FDA-cleared tool designed for early objective assessment, documentation, and care for better outcomes. That solution is the Provisio SIM scanner. For decades, clinicians have done the best possible with the tools available. But as this quote reminds us, when we know better, we should do better. Today, we understand that pressure injury development is fundamentally biologic and often begins before visual skin changes occur. By interpreting and integrating objective biology-based assessment into prevention, we can detect risk early, intervene more precisely, and deliver more consistent, equitable care. And with that, we can move beyond managing harm to preventing it and make zero harm a realistic, measurable goal for our patients. Thank you.
And Rhonda, thank you very much. That was great. Thanks again to everyone for joining us for today's webinar. As we like to say, prevention starts with early detection, and early detection starts with biology. And this webinar certainly demonstrated that. So thank you, Rhonda. We will now open it up. We've got a few minutes for questions. Please do submit any questions you have through the Teams interface, the Q&A interface here in Teams. And while those questions come in, if you would like to learn any more about how Bruin Biometrics can help your team move forward with zero harm, we'd love to talk. You can reach out to Dan or Rhonda or Karen, and their contact information is here on the screen. And I don't yet see any questions that have come in. So while we're waiting for those additional questions to come in, I'd like to share information about our next webinar on using rapid tests of change to accelerate your path to zero pressure injuries. Most hospitals have a pressure injury prevention protocol, of course, and however, few have a system that consistently executes on it. And the gap between policy and practice, those inconsistent workflows, the subjective assessments, and reactive interventions is where preventable pressure injuries occur. And closing that gap requires more than just new tools. It requires deliberate, structured change, and that's exactly what we'll cover in this webinar. We'll hope you join us for that webinar in April, and you can see the dates and times there, scan the QR code to register. And as always, even if you can't make it live, sign up anyway, and we'll send you the recording and the summary. So with that, let me check the Q&A list here. I still don't see any questions come in. Rhonda, you must have covered every question that everyone had so thoroughly. But if anyone does have any questions, go ahead and submit those now. Otherwise, we will go ahead and wrap up. We are at the end of time here, so at least of our scheduled time. And I still don't see any questions that have come through. So Rhonda, thank you again for taking time out of your very busy schedule. Same to everyone who joined the webinar. And we'll go ahead and wrap it up.
Thank you. Have a great day.
Thanks, everyone.